Today, we're looking at something that feels like a critical infrastructure failure, but it's happening right in plain sight. I'm
Mhm.
talking about the slow structural collapse of the local community pharmacy.
It really is a crisis. And, the implications for public health are pretty alarming. The data we have paints a very bleak picture.
How bleak are we talking?
Well, a recent NCPA survey, that's the National Community Pharmacists Association, it showed that 32% of independent pharmacies are seriously considering closing their doors this year. It's
32%.
almost 1 in 3.
Wow. That is just a shocking number, especially when you think about how much we rely on pharmacists for, well, for everything now. Flu shots, complex medication advice.
Everything.
So our mission today really is to understand the forces behind this. We're going to explore what seems to be a triple threat facing these businesses.
The perfect storm, really.
You've got this immense financial pressure, a severe pharmacist burnout epidemic, and then this powerful structural challenge from the industry's middlemen.
The pharmacy benefit managers, or PBMs.
Exactly, the PBM.
And it's all interconnected. You really can't talk about burnout without talking about the financial squeeze that limits staffing.
And you can't talk about that financial pressure without focusing on the PBMs. Okay, so let's start there with the foundational issue. The money. The financial squeeze. I mean, when almost a third of a critical sector is thinking about closing up shop, the business model has to be broken.
It is.
We've seen that 99% of independent pharmacists reported lower reimbursements for their prescriptions just this year. What is driving such a universal drop?
It really comes down to a fundamental shift in how the money flows, and it's mostly driven by some very complex regulatory changes. The really dire financial reports are stemming from CMS rule changes.
Ah, the dreaded jargon.
Yeah.
CMS rules. Can you break that down for us? What specific change just hit their bottom line so hard?
Sure. So essentially, CMS, the Centers for Medicare and Medicaid Services, they moved to require PBMs to apply certain negotiated discounts, what they call price concessions, right at the point of sale.
Okay, so that sounds good for the patient, right? Lower cost upfront.
It sounds good on paper, but for the pharmacy, the reality is that they are now forced to give these much larger immediate discounts. They get a much lower upfront reimbursement to meet whatever price the PBM has set.
So instead of that money getting clawed back 6 months later, which was already a problem,
Right, through what were called DIR fees.
now the margin is just instantly zeroed out, or even worse, it's negative right at the moment they dispense the medication.
Precisely, and that just ravages their daily cash flow.
And then you add in inflation, supply chain issues, all of that.
Exactly. Global crises, soaring operational costs. These businesses are really trying to operate on fumes.
And here's a fact that really surprised me, one that highlights how much they're struggling to even be a retail store anymore. Only 3% of shoppers who come in for a prescription actually make any other purchases.
Yeah, that's a tough number. It really indicates that patients now see the pharmacy as a purely transactional place, just a dispensary.
Which leads right into the next problem, the operational struggles.
It does. I mean, independent pharmacies desperately need to adapt to this digital transformation happening in healthcare. We're talking sophisticated inventory tracking, patient communication apps, EHR integration for clinical notes.
But all of that costs a fortune.
A fortune they simply don't have. They're constantly playing catch up with the huge chains that can invest billions in their IT infrastructure.
And we're also seeing these external economic pressures hitting them. The data shows fewer leads and referrals coming from doctors' offices.
Right, that's another compounding problem. When the economy is tight, patients often delay or even skip routine visits to their doctor to save on copays.
And if a patient isn't seeing their doctor,
The doctor isn't sending a new prescription or a renewal over to the local pharmacy, so the pharmacy's pipeline just dries up.
but the ones that are surviving, the successful independents, they seem to be pivoting. They're recognizing they just can't win as simple dispensaries anymore.
That is the key adaptive strategy right there. They have to become clinical service providers.
So what does that look like in practice?
They're expanding the clinical services where they can actually get better margins and, build real patient loyalty. This includes robust immunization programs, not just flu shots, but pneumonia, shingles, even travel vaccines.
And I've heard compounding is another big one, a real high-value differentiator.
Absolutely. Compounding lets the pharmacist create customized medications that the big chains just can't or won't handle. It's specialized care. And crucially, they're moving heavily into chronic disease management, things like medication therapy management and offering point-of-care testing.
Like blood glucose or cholesterol checks right there in the pharmacy.
Exactly. It secures their role as this essential, high-touch healthcare hub in the community.
Hmm.
But here's the thing. Even the pharmacies that are making that pivot successfully, they're doing it on the backs of an increasingly stressed and burnt-out
Well,
workforce.
if you look at a pharmacist's job description today versus, say, 20 years ago, it's a completely different profession.
Completely.
They're not just counting pills, they're managing incredibly complex medication plans, counseling patients on chronic conditions like diabetes, and, thanks largely to the pandemic, they are now primary public health vaccinators.
They are, you could argue, the most accessible healthcare professional we have, and that accessibility translates into just immense volume and pressure.
And the burnout figures really show that. They're staggering.
They are. More than half of all pharmacists surveyed report experiencing burnout, and that rate has been stuck, just plateaued near 60% for the last 3 years.
And the consequences are, frankly, terrifying. Burnout isn't just about bad morale. It means higher job turnover and, critically, a much higher risk of dispensing errors.
You're trading efficiency for patient safety.
It's a dangerous trade-off.
And we see that crisis play out differently depending on the setting. When researchers actually compared stress levels, pharmacists in chain settings reported significantly higher stress scores.
Higher than the independents.
Much higher. Their perceived stress scale score was 25.72 compared to the independents who averaged 22.82.
So why is there such a big difference? I mean, they're all under financial stress.
It really comes down to volume, staffing, and maybe most importantly, autonomy.
Autonomy.
Yeah. Chain pharmacies often impose these rigid corporate metrics that are focused solely on prescription volume and speed. How many scripts can you fill an hour?
Regardless of how many staff you have on hand.
Exactly. Pharmacists feel this constant pressure to meet quotas, which minimizes the time they can spend on actual patient counseling or detailed verification. Independents, on the other hand, while they have that financial stress, they generally have more professional autonomy and a stronger connection to their patients.
That context makes the next statistic even more concerning to me. Nearly 40% of chain pharmacists believe their workplace activities significantly reduce patient medication safety.
Let that sink in.
That's a direct admission from the professionals on the front line that the system is broken, that is compromising the quality of care.
It highlights this direct negative correlation. High workplace stress leads directly to the pharmacist's perception that patient treatment quality is suffering. If the system only rewards speed and volume, the essential clinical role, the counseling, the safety checks, it just inevitably gets pushed aside.
And this brings us right to the structural architecture that's creating this whole pressure cooker environment.
Yeah.
The pharmacy benefit managers, the PBMs.
These are the powerful, highly concentrated middlemen negotiating all the drug terms, and they have, in effect, become the primary adversaries of the local pharmacy.
The concentration of power is just immense, isn't it?
It is. The three largest PBMs manage nearly 80% of all prescriptions filled in the United States. And what's really critical to understand is that they aren't standalone companies.
Right. They're vertically integrated.
Exactly. They are part of these massive healthcare conglomerates that own the insurer, the PBM, and their own mail-order and specialty pharmacies.
So that vertical integration, it means the PBM has a built-in financial incentive to steer patients towards pharmacies, right? And away from competitors like the independent pharmacist down the street.
That's the entire game.
How exactly do they pull off that steering?
They use very sophisticated network design. They create what are called narrow networks, where the independent pharmacy is either just shut out entirely, or they're offered reimbursement terms that are so low they simply can't afford to participate.
And they also use marketing, I've read.
Oh, yes.
Yeah.
Actively. Sources document cases where PBMs send out marketing materials that are just inaccurate, sometimes falsely stating that a patient's local pharmacy has been kicked out of the network.
Just to push them to switch to the PBM's own mail-order service.
Exactly. And if a local pharmacy manages to survive that steering, they then face this immense financial and administrative assault, especially through audits.
These audits sound less like quality control and more like a shakedown.
That's how pharmacists describe them. Punitive, disruptive. They're looking for any tiny clerical error, a missing patient signature, a small inventory discrepancy that they can use to justify these massive financial recoupments.
And this is months after the prescription was already filled and paid for.
Months later, the sheer stress of maybe having to pay back hundreds of thousands of dollars over a paperwork issue, it just forces many small businesses to comply, whether the findings are fair or not.
And the contracts they have to sign are often non-negotiable, right? These unilateral, passive contracts.
Correct. But the real financial killer, the thing that creates this long-term uncertainty, it comes from these post-sale adjustments, specifically direct and indirect remuneration fees. DIR fees.
EIR fees. This might be the most predatory part of the whole system.
It's devastating because they are retrospective clawbacks. So the pharmacy fills a prescription today thinking they've made a tiny profit. Months later, the PBM imposes a massive fee based on these opaque performance metrics that the pharmacy has to pay back.
Okay, what kind of performance metrics are we talking about here? And why are they so opaque?
Well, the metrics are usually things like the pharmacy's generic dispensing rate or patient adherence scores for chronic medications.
But wait, a pharmacist can't force a patient to take their medication.
And that's the problem. First, the formulas for calculating the fees are often a total secret. And second, the factors that affect the metrics are often completely outside the pharmacist's control. They're being penalized for outcomes they can't possibly guarantee.
And the scale of this practice is just unbelievable. I saw a CMS estimate that pharmacy DIR fees increased by a staggering 91,500% between 2010 and 2019.
91,500%. It's a number that barely seems real.
How does any business model absorb that?
It doesn't. That number represents billions of dollars being clawed back from pharmacies, often forcing them to dispense drugs at a loss. If you're an independent, you might suddenly get a bill for $200,000 for work you did last quarter. That volatility is just unmanageable.
And this brings us to what feels like the real aha moment of this whole structural problem. It reveals the financial motive behind all this: self-preferential pricing for specialty drugs.
The data here is stunning. It's really evidence of market manipulation. If we look at specialty generics, these are drugs for complex or rare conditions. In 2022, commercial plans were reimbursing PBM-affiliated pharmacies an average of roughly $2,700 a month for these drugs.
Okay, $2,700. Now, for the big question, what was the actual cost for the pharmacy to acquire that drug?
The estimated acquisition cost was only about $66.
Wait, say that again? $66?
66.
They were reimbursing their own pharmacies $2,700 for a drug that cost them $66. That's more than 40 times the cost.
It's manufactured inflation, designed to profit the conglomerate. The PBM maximizes its own profits by funneling these prescriptions through its own high-priced specialty pharmacy, while at the same time, it offers the local pharmacy reimbursement rates so low they can't even afford to stock the drug.
And in the end, who pays for this inflated price?
The patient. We saw data showing that for these generic specialty drugs in 2021, a Part D member's out-of-pocket costs were, on average, higher than the estimated acquisition cost of the drug itself.
The patient is paying more out of pocket than the drug is even estimated to be worth. That is fundamentally broken.
So this intense pressure applied by the PBMs has finally catalyzed some major policy momentum, and it's focused on structural separation.
And the most notable example of that has to be Arkansas Act 624. It's set to take effect in January 2026, and it's a very explicit antitrust approach.
It's a bold move. It bans PBMs from owning or operating pharmacies within the state, period.
A complete structural separation.
It is, but it's already facing very serious legal challenges from the major PBMs in federal court. And the outcome of that case is going to set a huge precedent for similar laws being proposed in states like New York, Indiana, and Vermont.
And while the goal is obviously to protect independent pharmacies, there is an acknowledged risk here, isn't there?
There is. The law could potentially cause the closure of all 23 CVS pharmacies in Arkansas,
Which would impact 340,000 people and could create these massive, if temporary, access gaps.
That risk just underscores how serious this policy challenge is. And ultimately, these closures, whether they're independent or chain, lead directly to what we now call pharmacy deserts.
These are areas, often rural or in low-income urban communities, where the closure of the only local pharmacy just eliminates access to basic clinical services, counseling, rescue medications.
Everything. It transforms a problem of business competition into a full-blown crisis of health equity.
And there are some federal policy efforts trying to address this, right?
Yeah.
Like the Pharmacy Desert Act of 2023.
Yes, that's an attempt to incentivize new construction and relocation to these underserved areas. It's an acknowledgement that the free market, as it's currently dominated by these vertically integrated giants, is failing to maintain this vital public health infrastructure.
What stands out to me in all of this is just the profound misalignment.
That's the perfect word for it. We are asking community pharmacists to take on this massive, essential public health role, vaccinating the country, managing chronic disease, all while the structural framework of drug distribution, led by these powerful middlemen, is actively trying to make their business unsustainable.
So what does this all mean for you, the listener, in your own community? If the role of the pharmacist is rapidly expanding to fill these critical gaps in preventive and accessible public health, what does this growing crisis of pharmacy closures and pharmacist burnout actually mean for the future of healthcare in your neighborhood?
Because when that nearest pharmacy closes its doors for good, that quick access to clinical care, it just disappears.
Mhm.
And the burden shifts entirely back onto already overstretched hospitals and primary care offices.
It's a resource that we all rely on, and it is actively under existential threat today.